Again, many thanks to organizing committee for inviting me to this meeting. And my presentation next presentation is low instrumentation level selection in lung instrumentation for adult spine deformity, quite often degenerative scoliosis. When we can do fusion reliably short of a second, that means when we can stop the instrumentation at L5. This year's invited a lecture in IMS meeting last year in Washington, no disclosure. What's some definition of the lung instrumentation? There is no scientific definition for lung instrumentation or short instrumentation. And we participated in international SIS multi-center study, prospective evaluation of the elderly deformities, spine deformity surgery. They use 5-level instrumentation as a lung instrumentation. So in my presentation, lung instrumentation, that means more than 5 levels. And low instrumentation level is L5, not L4. And the corneal Carbangon, more than 30 degrees. And in my presentation, decompression or not is not considered for the instrumentation level selection. Of course, if I do L5S1 decompression, of course I have to go to pelvis or S1. So this is a typical instrumentation pattern for my presentation. Lung instrumentation start at L5. So look at these patients, again, 2 similar patients, nearly the same instrumentation pattern, kyphotic, and degenerative scoliosis. And the same, you can see the same age. This patient is 64 years old and 63 years old. We did different instrumentation, but did a different surgical strategy. For these patients, we did osteotomy at the apex L1 or T12, maybe L1, and instrumentation from T7 to L5 with a 1-year follow-up. Instrumentation holds up. And for this patient, we did L2 PSO, and we did instrumentation from T11 to pelvis. So why? 2 similar patients with a different surgical strategy. In my previous presentation, 2 similar patients, similar surgical strategy, but with a different surgical outcomes. And for these 2 patients, very similar, but we did a different instrumentation pattern. And one with shorter term follow-up, both patients go very well. So why? This is to stop L4 or to stop L5 or S1 or pelvis. It's a debatable question since a long time ago. But we do have some consensus. For instance, in this patient, we stopped at L5. I think there is no controversial for this patient to stop L5. And with 12 years follow-up, you can see both sagittal plane and corneal plane, both are well maintained in balance. And here's another patient, 55 years old, degenerative scoliosis. We stopped at L5. With 6 years follow-up, the patient goes very well. And for relatively short instrumentation, such as for this patient, we stopped at L5. 2-year follow-up, the patient goes very well. So for this patient, we stopped at L5. I think there is no controversial. But for this patient, 56-year-old woman, kyphotic, degenerative scoliosis. We did L2 PSO. We did instrument from T5. We stopped at L5. So question is, this line instrumentation stopped at L5. Will it hold up? With 3 years follow-up, okay, it holds, but I don't know in long term it will hold up or not. And for some patients stopped at S1. I think no controversial. For instance, in this patient, we did decompression from L4 to S1, decompression at this level, at this level, and we did the instrumentation from T12 to S1. I think there is no controversial for this. In 11 years follow-up, the patient goes very well, so no problem. So, but for this patient, degenerative scoliosis with L5S1, severe degeneration, disc degeneration, and we did L1 PSO. We long instrumentation from T3 to L5 to S1. So the question is, will it hold up? And with 8 years of follow-up, to my surprise, with 8 years of follow-up, it holds. Now the patient is 72 years old. So if you don't look at the follow-up, so if you see the patient, if you present this patient to the international meeting for case discussion, I think most of the surgeons, they propose to stop the pelvis. But in this patient, 8 years follow-up is one hold up. So why this is controversial to stop L5 or S1? Look at the literature. So if we stop at L5, the advantage is preserve L5 S1 motion and less invasive surgery and decrease the shoulder atherosclerosis. And this is well documented in literature. And many studies they say if you stop L5, if you stop instrumentation and as a cyclone, you have a major complication. Even you have a major complication, 75% versus 22% in instrumentation stopping L5. And regarding shoulder atherosclerosis rate, if you stop S1, it's 42%, but stop L5 only 4%. So you can see many important complications occur in the instrumentation stop L5 because of this. However, if we stop L5, you look at what will happen. So 67% of the patients, they will have advanced L5 S1 disc degeneration by 5 years. 15% of the patients require revision surgery, and many patients have scleral failure. In another study with long-term follow-up says revision surgery, if you stop L5, revision surgery rate reaches 25% by 5 years and 30% by 10 years, in 10 years. So that means if you stop L5 in 10 years, 1/3 of the patients they need revision surgery because of symptomatic L5 S1 degeneration. In part, this conclusion is okay. For instance, this patient with long instrumentation RCOST at L2 PSO, in 8 months after surgery, 2 L5 screws are broken. Unfortunately, the patient doesn't complain anything, so we didn't do revision surgery. 2 years follow-up, instrumentation is well maintained. Maybe this is because the patient is idiopathic sclerosis. If it is a degenerative sclerosis, maybe the patient will develop with imbalance inside of plane. And here's another patient. With 15 years follow-up, we stopped at L5. The patient doesn't complain anything, but at a regular follow-up in 15 years, we found 2 L5 screws are broken. And this is degenerative sclerosis. We stopped at L5. And 6 years follow-up, the patient complained local pain with the bulkiness of the instrument. We found L5 screw pulled out. And here is another patient. We started L5 with a 5 years follow-up. We found the blood was broken. So the further conclusion is correct. So that means if you stop L5, many mechanical complication. So look at this patient. It's a 69 years old patient. We did L3 PSO, and we started L5. And L5 at the beginning, immediately after surgery, the patient goes very well in sagittal plane and in coronal plane. But at 2 years follow-up, we can see the patient developed with a biplane imbalance, kyphosis, and the trunk shifting. And we proposed the revision surgery, and sometimes the general conditions of the patient still okay. And the patient and the family declined the revision surgery. At 5 years follow-up, you can see L5 screw pulled out, and with important imbalance. Now the patient accepted the revision surgery, but unfortunately, the general condition of the patient doesn't allow the patient to have a severe revision surgery. Here's another patient operated on in local hospital. This is her initial X-ray film, degenerative scoliosis. 1 year, we don't have her immediately after surgery X-ray films, but at a 1 year follow-up, it looks good. Okay? But at a 4 years follow-up, you can see the patient presented with severe sagittal imbalance. So very strange in this patient. Look at L5 as when this looks very healthy. Why the patient developed with important sagittal imbalance? So in my opinion, for this patient, PIL mismatching maybe this is an important reason. The second reason is a poor muscular tension. The patient is very thin. So the tension band of the spine is very, very weak. So if you stop L5, the muscles around the spine are not strongly enough to hold the spine. And this is degenerative scoliosis with healthy L5S1 disc. Because now many surgeons or many studies say if L5S1 disc remain healthy, you can stop L5. Many surgeons use this criteria as a guideline to decide when to stop L5 or S1. So look at this patient. L5S1 disc looks very healthy. The height of the disc is well maintained, no severe osteophytes on the posterior elements. So with the L2, we did L2 PSO, and we stopped L5. Immediately after surgery, it looks good, both in the cranial plane and the sagittal plane, and clinically, the patient is very happy. However, with 2 years follow-up, with time, you can see the patient develop with cranial imbalance. So the conclusion is L5S1 disc healthy doesn't mean if you stop L5, the instrumentation will hold up. And sometimes this is another L5S1 disc very healthy. We stop at L5, but as you can see, the patient developed with cranial imbalance with time. Immediately after surgery, that's okay, but at a 2 year follow-up, imbalance. Why in this patient, L5S1 disc very healthy? This complication related to L2, L3, L4 multi-level subluxation. Subluxation means unstable. This is peace study we participate. This is an international multi-center study financed by L-Spine. So look at this patient. L5S1 disc looks healthy. Okay, healthy. And look on the CT scan, L5S1 facet joints looks good, not so severe degenerate. So we stop at L5 immediate, but with 3 years follow up, you can see little by little imbalance in cranial plane. So in this patient, the main reason I think is related to L3, L4 subluxation. So if you have low-level subluxation, so try not to stop L5, try to stop S1 or sometimes quite often pelvis. So look at this patient, 57 years old, degenerative scoliosis, and very fractional curve is very rigid. This on the supine position, standing position, bending film, you can see the relationship between L5 and the pelvis doesn't change. It means it's very structural. Even L5 S1 disc looks very healthy. So you can see L5 S1 disc looks good. But after surgery, you can see imbalance immediately after surgery. So in my daily practice, I don't do it very frequently. So, and when we can stop L5, the literature say if the patient is not osteoporotic, it's not age, it's not older, there is no fixed oblique pelvis, and it's not a biplanar imbalance. Here, this is a well-documented criteria in literature. Here, I like to add, if the patient has a good muscular control, you can try to stop L5. And if you anticipate your surgery are able to restore the balance in a sagittal plane and in the cloud plane, and no 3-column osteotomy below L2. So that means if you do osteotomy, 3-column osteotomy below L2, L3, L4, I don't stop L5. I stop pelvis. And no subluxation below L3, L4. And here, important point is healthy L5S1 is essential, but it's not decisive. So when you have L5S1 healthy disc, it doesn't mean you can stop L5. L5. So the patient must be not osteoporotic, not aged, not a rigid distal curve, and the patient has a good muscle control, etc. So look at this. I stopped at L5 for this patient. The patient is only 44 years old. It's a young patient. L5S1 disc healthy, so I try fix instrumentation at L5, even it's a long instrument. So 2 years follow-up, the patient looks good. And here's another patient, 38 years old. So I stopped at L3. I stopped at L5, even I did a 3-column osteotomy here. So 3 years follow-up, it's okay. And 56 years old, L5S1 disc looks good. So I did L2 PSO. I stopped at L5. 30 years follow-up, okay. In 50 years old, young patient. I stopped at L5. 30 years follow-up. It's okay. It's okay. And if it is not a long instrumentation, of course, you can try to stop L5. And if the patient has very strong muscle control, you can try to stop L5. Look at this patient. We operated her at the age of 64. The patient has strong muscle, very good muscle control. And 8 years follow-up, you can see it holds. Okay. And here's another patient, 54 years old. I have. In the revision surgery, it doesn't mean you have to go to S1 or pelvis. Look at this patient. The patient was operated on in another hospital. It's type B, And L5S1 disc looks good, young patient. I did osteotomy at APEC L1, and I stopped L5 in this patient because the patient is young, and she has L5S1 healthy disc. And with 9 years follow-up, instrumentation holds. So how important the healthy L5 disc level is? Look at this patient, L5. This is 64 years old. It's type C. And L5S1 disc looks good. Immediately after surgery, the patient presented with imbalance in cranial plane. But with time, at 1 year follow-up, you can see this imbalance improved spontaneously. I think this is because of L5S1 disc. So again, I like to introduce you the cranial imbalance pattern in adult scoliosis. Type A means no imbalance. Type B means imbalance to the concave side. And type C, so that means imbalance to the convex side. So if it is a type B, convert to the concave side. If L5S1 disc is healthy, if it is not osteotomy below L3, you can try to stop L5. So look at this patient. We stopped L5. So 2 years follow-up looks good. Good. And here, immediately after surgery, the patient has imbalance, but 2 years follow-up is spontaneous improved. So this is my conclusion. When you stop L5, healthy L5S1 disc and facets are not enough. It's important, but it's not enough. Cranial imbalance pattern must be considered. And if you don't do 3-column osteotomy below L2, or if there is no big subluxation below L3, L4, you can stop L5. And again, the patient has stronger muscle control. So if you stop L5, I must tell the patient, probably in 10 years or 15 years, revision surgery may be required. So if you believe the revision surgery in 10 years or in 15 years is reasonable and it's acceptable, you can stop L5. You can stop to L5. So the age is a very important thing. Thank you very much.